יורית היא חברה ותיקה שלי, שאני מכיר מאז שהיא הייתה אולי בת 13. שהיינו ביחד בתנועת נוער הבונים באוסטרליה. היא באה ממשפחה מאוד ציוני ובין מנהיגי של קהילת היהודי בסידני. אחותה גרה בצפון בקיבוץ קדרים, והיא סופרת ואומנית אדירה. ג'ודית עצמה גרה ועבדה בארץ לתקופה. היא למדה רפואה בסידני ועשתה התמחויות ברפואה משפחה ברפואה משפחה, ואז בטיפול תומך. בתחום של טיפול תומך, היא עבדה בכמה וכמה מקומות בסידני, ולאחרונה היא מנהלת התוכנית של Palliative and Supportive Care ורפואה אינטגרטיבי.
Supportive care and integrative oncology, yeah.
במרכז יחסי חדש ומתקדם בסידני. המנהלת שלה הייתה אצלי בביקור בארץ לפני שנתיים, וסיפרה לי עד כמה אדיר התרומה שלה לרוח של כל המוסד. יש לה סטטוס של associate professor ברפואה משלימה, והיא גם קלינאית וגם חוקרת. לשנים האחרונים היא עבדה גם בנושא של קנאביס וגם בנושא של hallucinogenic agents בטיפול, לא?
That'd be fun.
Yeah, I thought you'd done some work with LSD.
Oh, I'd love to, but no, not yet. But integrative medicine, yeah.
Okay, והתפרסמה בין randomized controls הראשונים בתחום של שימוש בקנאביס בגלייובלסטומה מולטיפורם במשך החודשים האחרונים, ואני חשבתי שזה היה תרומה גדולה לקבוצה שלנו לשמור ממנה. Judith, don't feel like you need to speak in Hebrew.
I can't speak in Hebrew well anymore, but it was really nice to actually understand your Hebrew and everything you said. So that was a nice gift. No, that's great.
Okay, so I think we've got now to run to 35 minutes past the hour. Our hours are different, so I'll leave it to you now, Judith. So you can
that's
please.
Right. So
if you want to share screen, you certainly can.
Yes, I will. So hello, everybody, and thank you for the lovely introduction, Nathan. I'm only going to speak English. I understand Hebrew, so if you need to throw words in and out, that's absolutely fine. But haven't lived in Israel now for close to 20 years. It's passed very, very quickly, and but I speak to people there all the time. I'm going to, I thought Nathan asked me and I couldn't say no. So I have put together sort of a bit of a talk on the work that I'm doing in two main studies that we're doing in cannabis, but I would also, I was thinking I should probably share the paper as well with you. So I will flick back and forth to the paper. And I didn't really know how you run these meetings, and I couldn't get that much information at 3 a.m. from Nathan. So we'll see what happens. Yeah, go on.
No, that's good. Just get in the presentation mode. Great.
Yep. And so what I'll do is I'll very quickly run through how this all came about, this research, and then talk really about our GBM study that was recently published, and then allow some time for discussion. But also, if you want to interrupt me anytime along the way, just do, because I'm speaking to people who've got much more expertise than I do in the field of prescribing cannabis. I'm a clinician, and always trying to be a researcher, and in integrative oncology, which is a relatively new field here in Australia. And I'm at a centre. There's a hospital called Royal Prince Alfred Hospital, and we're the cancer centre of that hospital. It's called Chris O'Brien Lifehouse, and it's now in its 7th year or 8th year. I've been here for 6 years running the supported care program. So you all know about cannabis and and the endocannabinoid system, and I'm not going to speak about that. I'm going to jump really to my experience as a clinician and how I got involved in talking about cannabis and how I've got involved in these 2 main research projects, and a little bit about them, and then the results of our GBM study. So cannabis prescribing has only been around for the last 5 years. All the Israelis came out and started talking to us here in Australia with our government, and as a result, the system was developed. The system was developed slightly differently, I think, to Israel, in that what they have done, rather than us giving people licenses to then go off and get cannabis from elsewhere in Australia, and I don't know how this is in other countries as well, but it's the clinician's responsibility who makes the application, chooses the product, prescribes it, and follows up the patient. And so the prescriber of cannabis is the person who then actually chooses the product, writes the script. We get an approval, it goes to our pharmacy in our hospital and administered to the patient. So it's there's no sort of middle people that much, which means that there's a lot of responsibility on how the hell do you prescribe this product, how do you prescribe it, what do you choose? And so there's a lot of angst about it, prescribing cannabis still in Australia. I've been prescribing now since one of the first prescribers in Australia. The system has got easier, and as a result of it rolling out quite slowly, there was this real need to understand what we're prescribing. Does it work? Doesn't it work? What are the side effects, interactions? Because it's our full responsibility as clinicians. And so as I've been working in this space, the 3 main reasons that people come and see me are either for refractory symptoms in advanced cancer patients. I have a specialty in palliative care. Palliative care in Australia is a 4-year specialty, and so I must like studying, because I did that when I came back from Israel after studying Rafat Mishpacha in Israel. Cancer or cancer treatment-related symptoms. I see a lot of patients with chemo-induced nausea and vomiting. We were one of the main centres for chemo-induced nausea and vomiting study that was recently published by Peter Grimmerson, one of my colleagues. And so anyone that didn't fit the study, I prescribed for. And the other question and the other area that people often come and speak to us is the cancer itself. And so we all know about symptom clusters, and that cannabis is absolutely fantastic when you prescribe it for pain. It also will help someone sleep and their anxiety and maybe their nausea. So you're also reducing polypharmacy. And so the potential benefit of using cannabis is that you are obviously treating more than one symptom. And in palliative care, and as we keep people living longer with cancer, this is really important to look at the reduction of polypharmacy. And so for that reason, I put my hand up to be very involved in this space, because I'm very interested, and my department is, not just advanced cancer, but it's also acupuncture, exercise, yoga, meditation. We've got the psycho-oncology team. It's sort of looking at alternative and innovative ways to treat people living with cancer and reducing polypharmacy. And we also know in palliative care and in the palliative care space that good symptom management requires knowledge of how to apply evidence. It's about reducing suffering, doing no harm, but also prescribing using the best model of using best practice guidelines if you don't have the evidence. And that's really where we're at with cannabis in advanced cancer. And so the group that the one of the research projects that I'll speak to you about is called the Australian Centre for Cannabis Research, and it is, or ACRE. And these are publicly developed guidelines, which are available on the website, and we use these systems to look at how we can best manage people with anorexia and cachexia, going through the very well-known pathways of, evaluating the patient that has advanced cancer and refractory symptoms, working out other ways to manage them. If they have depression, treating that. If they need a prokinetic, if all of this is ineffective, then looking at evidence-based guidelines, and that you could then suggest cannabis. So in Australia, it's very much for refractory symptoms, and this was related to our study. The second refractory symptom out of the three that I'll talk to you about for this study is refractory nausea in advanced cancer. And you also know that if you follow the guidelines, and Nathan knows these back to front, having written every second chapter in the palliative medicine textbook, I think, lately, but having gone through the textbook and edited every chapter, we all know that these are pretty well-established now approaches to managing nausea and vomiting in people with in the advanced cancer setting. And so what we were looking at is developing a study for refractory symptoms in advanced cancer. So New South Wales government gave us $3.5 million, which is very nice. And some of it went to develop resources, and some of it went to running this study, which is I'm trying to read the top of my slides, which I actually can't see, but you can see them, can't you? Which is this observational study called the CARE New South Wales trial. And it was coordinated by this Australian Centre of Cannabinoid Clinical and Research Excellence, which is supported by the NHMRC, which is a large government funding body, and based at the University of Queensland. And what they did was they got all of us involved from around Australia, people working in the space, and we put together an open label observational study, prospective study, to look at our prescribing and the impact it has on refractory symptoms of nausea, anorexia, and pain in the advanced cancer patients, with a prognosis initially of 6 to 12 months. Very hard to recruit with a prognosis 6 to 12 months, and we've just moved it to 3 to 12 months, and after a couple of years getting this through ethics, so it's taken a very long time. The CARE New South Wales trial is now running, and we're a site, and there are quite a few sites around Australia. It's only in New South Wales. We're looking to recruit 600 patients. It's the largest international observational study of this kind. And the idea is to enable the provision of monitored legal access to cannabis. The patients receive the cannabis for free, and they're closely monitored by the team. And it's really to strengthen the evidence base of cannabis medicine prescribing and safety, so that people feel more comfortable, particularly doctors, because doctors are the prescribing, in how to prescribe cannabis. And we're looking at the effect on the symptom experience of people with advanced cancer, the side effects of cannabis, what's the best dose is, the pharmacokinetics and pharmacodynamics information, and with the hope to develop ongoing guidance for prescribers, probably similar to your green book or whatever you have, and I'd be interested in learning from that. We're aiming to recruit 600 patients over 3 years, and with a range of products that are available in Australia, and with those 3 index symptoms. And we've developed a suite of patient-reported outcome measures. It's all electronic. It goes to people's homes, and the patient fills an electronic diary daily. They hang around in day therapy and do the PK and pharmacodynamic studies after the first dose, and then they just come in and see me or see one of the investigators regularly. And they keep a diary. It's a lot of paperwork. And it's much easier for me to prescribe than to put them on the study, but it's really important to get people on the study. And so we are. So that's the first study. That's a study that's ongoing, and it really has a lot of centres around Australia. The second study, which we've just published, and I can either go through the slides as a summary, but I've also got the paper if you want to have a delve deeper into it. And I'm just going to keep an eye on the time as well and interrupt me at any stage, is about the cancer itself. And the big question is, can cannabis actually control cancer? And Dedi Meiri and our team are in a lot of discussion about this study and the next phase of this study, and those discussions are continuing, but we're actually in the process of running the next phase of this study. Now, this study was it was a phase 2 randomized trial without a control, but looking at 2 different ratios of medicinal cannabis in patients with GBM. The lead investigator is actually a naturopath, Janet Schloss. And it's a really interesting team of surgeons, oncologists, and myself as a supportive care physician, statisticians, and experts in endocannabinoid system and cannabis. And so this study, we were very excited. We got to present it at ASCO as last year, and have just published it now in Frontiers in Oncology in May. And it's a phase 2 randomized clinical trial assessing the tolerability of 2 different ratios of medicinal cannabis in patients with high-grade gliomas. That's the poster that we presented, and the background, and I can either I'll go through the slides. The paper's very wordy, but I will sort of speak a little bit to really where we're coming from. The basis for this whole study was to look at, we acknowledge the cannabis is being used for cancer-related symptoms. We know that the patients with recurrent GBM or have inoperable GBMs have a poor prognosis and are a very vulnerable population. And GBM is glioblastoma multiforme, and so we wanted to see, first of all, is cannabis well tolerated in this population, and does it improve the quality of life of these patients? And that was really the aim of this study. The next phase of the study, and also a component of this study, was starting to test the waters of the efficacy. Does it actually have some sort of signal that it's prolonging life or improving the survival rates? And the next study is a study with looking at it from the time of diagnosis. So few trials have assessed actually the quality of life in cannabis in patients with GBM receiving cannabis. And we also wanted to know if a high dose THC product was actually going to have negative effects on our patients. So it was investigating the tolerability of 2 different ratios of cannabis. One was a whole plant CBD THC product, and these products are both from a company in Whistler in Canada. It was a cold extract whole plant with a very specific terpene profile, but 1-to-1 ratio of CBD to THC. And the second product from the same company and very similar terpenes, but the difference was the THC ratio to CBD. And we wanted to look at, first of all, the tolerability, but the second effect was, are there signals to say that it actually is prolonging life? We know that Guzman et al. And a group, and I can't remember if they're Spanish or Italians, injected whole plant cannabis into GBM patients and showed into the tumours and showed some potential benefit, and that GW Pharma were doing some study with Sativex looking at the impact on GBM patients and developing products in that space. So it's an interesting space, but nobody has done quite many studies in this space. We also want to look at the absorption. of cannabis in the sublingual form, and the safety, the dose range that people found comfortable to use, and the impact on quality of life, and the potential to combine it with standard treatments. And we were using the RANO criteria for GBM, so looking at the MRI at baseline and at 12 weeks to see if there was any change in tumour. So everyone had to have measurable tumour at the start of the study, and we're still following up some of the study patients a year and a half later who are still alive. So we have two groups of patients, one with that received a 1-to-1 product and the 2-to-1 product. We did an MRI at baseline, regular bloods. We used the FACT-BR as a quality of life measure. And we were also evaluating all the endocannabinoid levels, and we've got a few more publications to come on that. And we then continued to see them on a regular basis, 0, 4, 8, and 12 weeks, and ongoing follow-up up to 120 weeks post study. After the 12 weeks, they then went on to a similar cannabis product, but not the same cannabis product, which they needed to pay for, but almost all the patients continued on cannabis. The cannabis was given, so we had over 900 patients register for the trial within the first 3 months. And not all of them were eligible for the study, but when you put out that there's a cannabis trial for cannabis in brain cancer tumours, everyone was jumping because there's a lot of interest. And so we only had funding to recruit 90 patients, and we knew we'd have a 20% dropout. And so 556 were actually excluded. But they were travelling from all over Australia to New South Wales and then flying back. And so we had people coming over from Western Australia, Queensland, all places for the study. We ended up recruiting 92 patients, but by the time the study started, we had 88, and they were in two arms. So one arm received the 1-to-1 and the other the 4-to-1, and there was an attrition rate of about of 12.5% due to death, to progression of disease, or going off for other reasons. And when we looked at our results, we had about 50% were, a bit more than 50% were female, so it's about 1-to-1, mainly Caucasian and English speaking, because they needed to fill out a lot of questionnaires, and that is who. And the treatments were, the majority were on temozolomide, a few received Avastin, lomustine, and about 30% were on dexamethasone. Some of them most had at least one craniotomy, but a number of them had already had, about a quarter of them had 2. Most of them were ECOG, 60% were ECOG 0 status, and a few of them were ECOG 2, and none were ECOG 3 or 4. Now, this is very tiny, but I will summarize it to say that when we looked at the FACT-BR, what we were really interested in was the benefit on quality of life and what symptoms cannabis actually improved. And we found a significant improvement in sleep in both groups. So patients, it was a once daily dose. People started on the lowest dose and just titrated to the highest dose they could tolerate at night without waking up groggy the next morning. And sleep was the main symptom that responded well. And we know that with GBM patients, sleep is one of the most difficult symptoms that people experience. But what we found that was really interesting was actually there was a benefit in their benefit to their total function, the physical function, and also their contentment with quality of life, with very minimal side effects. So that was quite an interesting finding and quite an exciting finding. So not only did yeah,
that's a term I've not heard before, contentment with quality of life.
I know. And it's interesting, it's in the fact BR is contentment with quality of life rather than just quality of life. And
so that's distinct from global quality of life.
Absolutely. Distinct from global quality of life. So it was broken down into enjoyment of life, physical, and contentment with quality of life. So these people just felt, so either they were stoned and didn't care, don't know, but I don't think they were that stoned. But it was just that people felt more comfortable and happy with their quality of life over time with this study, which is one of the scores. And the side effects were quite interesting in that initially people had quite a few side effects in the first 4 weeks. And over time, with titration up of their dose over time until they reached the toxic, they seemed to tolerate the side effects better. And the main side effects were dry mouth, tiredness, dizziness, drowsiness, and impaired motor coordination, which was very minimal. So overall, we were very happy that people tolerated it well, and there was no significant changes to their bloods other than a slight rise in gamma GT in some of the patients that received temozolomide, but no other significant, and we used the CTCAE, so no other significant symptoms. We were also looking at just what happens to the patients over time, and at the end of the 12 weeks, using the Raynaud criteria, how many had, so we had 27 patients who didn't complete the study. We had 3 people who had partial reduction, 8 people who had, I don't know what complete response means, 8 people who had partial reduction of disease, 34 who had stable disease, 3 who had reduction in disease, and then there were 11 who had 16 plus, or a bit more than, there were 27 who had progression of some sort. It's a very short window, and we're still following them, so we've still got.
Judith, the patients that didn't complete, does that mean that they stopped taking the cannabis before the evaluation times, or?
So 9 of them died, and some of them went on to have further surgeries or other treatments, or didn't complete the study. Right. Yeah, I will have to look at I'll have to go to the paper to remember the exact breakdown, but I'll let you know. And so from this study, what we could conclude was that a single dose of THC and CBD 1-to-1 was the best tolerated product compared to the 4-to-1, and we only compared 2 different products, that it was well tolerated in the population and it improved sleep, functional well-being, contentment with quality of life. And that enabled us to then choose that product for our next study, which will be in looking at the potential benefit in combining it with chemotherapy. But we were really keen to show that there was a way of improving the quality of life of people with GBM. So the clinical oncology group of neuro-oncology group are very interested now in partnering and saying, where to from here with regard to if this is well tolerated in the population of cancer patients. Seems to be safe from the numbers that we have done with definitely with temozolomide. We're not sure, that we had very small numbers on lomustine. Then is it safe then to move to the second phase of a study? And so that's where I would really just wanted to give you a snapshot of what we've been doing in this space. So obviously we're looking at, who are responders and who aren't responders, who benefits more. The pharmacokinetic and pharmacodynamic data from both our studies will really inform how we prescribe, and if you can pick up the characteristics of which patients do better with cannabis than others, which patients don't tolerate it, who needs higher doses, who needs lower doses. But overall, the doses that people needed with cannabis were between 10 milligrams of THC, 10 of CBD at night, to up to 27 milligrams of THC equivalent at night. And open up for discussion, questions.
Judith, can I just ask, following up on the stuff on your comment about quality of life, I got the impression earlier that you'd said that what was improved was contentment with quality of life,
Yeah.
but not the total quality of life itself.
So in the fact BR, I'm just trying to find the, sorry, I'm just on the paper itself because
in studies of quality of life in patients with cancer, it is very, very infrequent to see any intervention that improves it. And at best, what one sees is delayed deterioration. So if in fact there was actual improvement, that would be very curious, that would be very interesting to me.
So the fact BR, I know, and the fact BR is an interesting questionnaire in that it asks about enjoyment of life, which didn't improve, if you can see the p-value here. And when you look at contentment with quality of life, there was an improvement over time with both products with a p-value of 0.027. So obviously the p-value for with it's, you know, it's a reasonable measure, the physical functional and the functional well-being, the p-value is 0.06, 0.04. So it's a reasonable signal. It's not, but that's what we could conclude from that. And that's the measure that we used.
Is that the tool going into the next studies?
Sorry?
Is that the tool that's being used in the other studies as well?
The FACT-BR is mainly so I don't know if you use the FACT-G, FACT-BR, any of those measures. I'm just seeing if I've got the full in the supplementary, if you really want all the detail. The study is free. This is all free online, this paper, but I'm just, if I get to the supplementary data, I can open that up and just go through the sorry, I'll share that. I'm not sure if I'm sharing any screen right now, am I?
No.
I think I am now. I think there's all the supplementary data going through it's all our bloods, but there is actually looking at the details, which are the rest of the questions in the quality of life tool. Goes on to taste changes, appetite changes, which didn't show a significant benefit. And then as you can see, we asked a lot of symptoms and went through, we were looking really for signals of safety, but also secondary benefit in quality of life. And the FACT-BR is the main questionnaire that we use in patients with brain cancer. So improvement in concentration, and as you can see, there's a lot of stuff there. So we just pulled out the main ones. And insomnia, there was a significant benefit.
Judith, it's Simon Ween.
Yeah.
Judith, a couple of things. One, what did you find on the blood samples from the sublingual? Did you do sublingual versus oral swallowing or not, or just sublingual?
No, so we used an oil that we instructed the patients to have some fatty food, hold it sublingually for a minute and then swallow the rest. And that's what I'm mainly using. I'll learn from you guys. We only had the single, we only used an oil. We're obviously looking at other ways of delivering the cannabis for better absorption and more reliable absorption.
Yeah. No, so the traditional teaching is to use sublingual, not oral, because of the absorption, because of the acidity of the stomach. Have you done any or looked at any studies comparing sublingual to smoking, inhaling?
Not in the GBM patients, no.
No.
And we are looking at different delivery techniques for our next study. Depends on funding as to what you can get. We actually haven't had smoked cannabis available, inhaled cannabis available until about a few months ago. And it's in Australia. It's something that we can prescribe. So that's also very limiting. And the only, we've got some nano sprays, which are ridiculously expensive, that are available. Some wafers have just come out and some capsular forms, but most of it has been oil. And at the time of the study, there wasn't much more available.
Okay.
We're looking at inhaled cannabis for anorexia, though. So, yeah.
I didn't note, was there a control group in this study?
In the GBM study, no. And so it was really an observation between two ratios of cannabis. So that's a big negative, that's a big gap. But we really just wanted to have a pragmatic study so that we could see if it was safe to move forward to do an RCT with the placebo.
In some of these studies, I always think it's worthwhile, especially these GBM, to ask the family, to have observations from the family or for the carers. Was that part of it? Is that an idea to carry that forward?
So very much a part of it is is that the patient could have the carer as their proxy. And we're actually in our next study will be with the patient advocates are working with us to work out how best to have the carer's voice in there as well. I think that's really important. And I think it's because observing, as you know, as people become more cognitively impaired or have significant cognitive impairment, really hard to report, I feel better. Yeah.
Mm-hmm. A lot of our patients want cannabis here. We probably more than 80% of the patients in our institution request or demand the cannabis. And I think it'll be very difficult here to do a double-blind controlled study. So we sit in great admiration and awe of your ability to have done a proper study.
Yeah, there's no placebo though.
Yeah, right. Yeah. Well, my impression is that cannabis is very effective, in helping sleep, which not in all patients, but in some, it's really can be quite dramatic. And my second impression is that it, and I've had this from a few patients, that it dramatically improves their anxiety, their existential distress.
Yes.
And I think that's of tremendous value. So my question to you would be, in your study that you did now, can you break down to see if it's just anxiety or quest for deeper nature?
It's really, first of all, it's really hard in GBM patients to tease that out because it's quite a heterogeneous group of people. It depends on the part of the brain that's affected.
Correct. Very good, yeah.
Without steroids. I find I really struggle personally with people with midbrain GBM tumours or corpus callosum involvement when you're even assessing anxiety or other symptoms. People with frontal lobe disease are different from people with temporal lobe disease. And so it is a very complex piece I think, to tease out in this patient population. With our study with the advanced cancer population and and also just prescribing, I think that anxiety, people's and anecdotally and from my own prescribing is that people's response to their pain may be an improvement in pain may be related to their improvement in their anxiety and their existential angst around the meaning of the pain.
So from this phase 2 study you just did, what would be your sort of concentrated endpoints for a phase 3 in GBM, given the diversity of symptoms? What would be,
Well, we're just trying to apply for a grant at the moment on this, and I guess what we're looking at is twofold. Is this reproducible with different products? So are we seeing that, if you can improve the quality of life for people with GBM, that's great. And if you improve their perceived quality of life by their carers, I think that would be a really interesting endpoint. I think the carers found it easier to their reflection, and this is only, just from speaking to them, and we haven't written this up, is that there was a sense that it was easier to live with the person with GBM because they settled well at night and were more relaxed during the day. It is the second endpoint for us. The harder endpoint is going to be survival, but the other endpoint is improving quality of life. and whatever, and if that is just quality of sleep and reduced anxiety and distress, then that's great. So what are your thoughts?
So how do you work in the confounders of, you know, all the neuropsychotropic medications, including benzos and major tranquilizers and all that stuff?
Yeah, and that's so at the moment we just.
But in your study, I didn't see that. I didn't see that in your study.
We didn't report on that in this paper. We didn't report on all the co-founders, all the other medications. But that's the next part of the research. This is a very small study. Is, you know, what happens to benzos and polypharmacy, and but there were no increase in psychotropic medications during that period of time, which I think is important as well. So there was no added use of, and that was each person that had an adverse event. We had very long discussions. Most of the adverse events were related to, one was related to seizures, one was nausea when they had it on an empty stomach, and but there was no significant added use of psychotropic medications during that time. But it's a very complex group of people to run a study in, because they're not, everybody has a different progression. But it's interesting. I think it's important to, number one, say it's safe. And like 80% of your patients with cancer are expecting cannabis, 80% of patients with glioblastoma multiforme are expecting cannabis.
You know, a lot about the glioblastoma, they want the very high CBD.
Interesting.
Because they've got a belief, and I emphasize the word belief, that it can help, you know, shrink the tumors or something like that.
It's not only the CBD. There are many that use the Rick Simpson oil, which is high with both THC and CBD. Yeah. So I'm surprised that so many people wanted to be on the study, because it's one group of patients. Well, all of our patients almost want the cannabis and they have great expectations. But this group of patients, they really believe it's a treatment. It's because there was some publication about the patient in Israel and many believe it is. So I think what we prescribe when we write for certain percent, the highest percent of THC, they prepare the oil, it's much higher. So
yeah, so and I really struggle with people self-prescribing Rick Simpson oil type products, because it often has a quite a significant hangover for the patients, and their challenges then on their quality of life. So we really wanted to see, and it was interesting, we assumed that the higher THC product would be better. People would like that more, but actually they had more side effects and less improvement overall compared to the one-to-one. So the one-to-one was better tolerated, and it'd be interesting to see how our data and our next studies compare then to the GW Pharma that are using the one-to-one with the GBM patients as well. So it's the challenge, isn't it? You know, and there's a big difference between Rick Simpson oil and almost pure CBD. So, yeah. Any other questions or comments?
Well, if there aren't any further, then I just want to take the opportunity of thanking you. Sorry, 1 second. So I just want to take the opportunity to thank you and extend an invitation that you're welcome to join us any Sunday night where there's nothing good on the television at this time on this channel.
That'd be really interesting. I think
it is a regular Zoom event, right. And you know, I didn't actually see here how many people were on the. We've had 14 people today, but we we have anywhere between 10 and 40 participants on any Monday afternoon, on any Sunday afternoon. I thank you very, very much for sharing your inspirational experience with us. Because although it's I guess a lot of people here have got a lot more hands-on, there's not been a lot of good quality research done here in cannabis in this sort of setting, and you've shown the way very nicely.
I think in Australia we're really focusing on getting in there quick to get as much research done as possible before we legalise recreational use, and it goes out the window and you'll never be able to get another piece of research done again. So we're pretty keen to get as much done as possible in the most pragmatic way possible, and always interested in collaborating to see if results are similar in different settings around the world. So always good to...
I do actually, I have one more question.
Mm-hmm.
Is that your spectacular office, or is that just a background?
No, I'm actually sitting on my... No, I'm actually sitting on my bed, and the background is a whole lot of pillows. And so I thought, look, it's it's late at night. I'm just going to kick my husband out. He loves watching cricket. These New Zealanders are good, and if Australia is losing, that's even better. So he's doing that. And so I'm just sitting in my bedroom with a spectacular office behind me. I think, will we see any of you at the MASK conference in the next few days? The Multinational Association of Supportive Cancer Care.
Oh, no.
Nah, no.
Lacey, I wanted to ask if it would be okay to post a recording of this meeting for the benefit of those who couldn't make it. That would be okay by you?
Yeah, that's okay by me. And there's also the paper, the reference, if you go on to Frontiers of Oncology, it's free online, and we're very happy to be scrutinised. It's been through many different reviews in different places, so it's interesting, and to always have lots of questions being asked. But I think it's just really exciting to be able to improve the lives of these patients. So I'm quite keen, and I'm really keen to learn from all of your experiences on how to prescribe cannabis in the palliative care setting and in the advanced cancer setting, because we've sort of been thrown in the deep end to say not only learn about it really, really quickly, have a limited number of products that you can actually use, and as doctors, you're the only prescribers. So we're just going...
To only speak for myself, I think we're prescribing what's not even defined as a drug, with little to no data and less training than data, for sure. I think for most of us, it's kind of, see what sticks.
And Yakir, who's prescribed over 5,000 licenses.
All right. And we'll be happy to see it, to connect our experience with you, because we have a lot of side effects, abuse, psychosis, legal issues. And since I didn't ask you, but I want to ask, what is the market business of, it seems a very complicated research. So someone has to pay for this. And
so the government, yeah.
The government.
Oh no, the government paid. The government paid for the study, the observational study in the advanced cancer group. The GBM study was pharma. So that was actually a pharmaceutical company that gave us some money to do, and that's how many patients that we could study. But now they're thinking, oh, but then the next stage will be interesting. And so there's that difficulty now, it becomes a pharma study, the next stage.
The pharma study, the aim is to improve survival, it's more money. But we know that the chance, even in GBM, the chance is about zero. So, and in our experience, and according to your results, it seems that it might mitigate a few symptoms. And to focus on GBM, I don't think it's the best population. because pancreatic cancer or lung cancer have more symptoms, as Professor Cheney described. So I think it's the wrong population.
I think there are also studies in Australia in pancreatic cancer that are happening at the moment. I think it's the most, I've worked with GBM for the last, I'm very interested in GBM personally, but I think it's actually a really interesting population. That study was also conducted in the rooms of one of our neurosurgeons that is very interested in the space, which probably helped us get the funding. But it's quite promising to see if it does have some sort of, even if it has a steroid sparing benefit that improves quality of life. So watch our data. I think but I agree, the pancreatic cancer patients, who are the main group that I prescribe for day to day, are the ones with the more complex symptoms that get the improvement in their nausea and their anorexia and their pain pretty quickly. Their improved quality of life. And if that has a added benefit, that'd be nice too. But, at least you're improving the quality of life. But that's pretty easy to do for the pancreatic cancer patients, I think.
Not good so easy, but it's easier.
Easier, definitely. Definitely. I think we chose a hard group.
Yeah.
We're a very big neurosurgery hospital. We didn't actually conduct it in our hospital, but there's a lot of interest in that space for us. Yeah, but I agree. I don't know. Are you running any observational studies with your patients in your care?
Mainly for one of the problem is the survivors, and mainly younger patients who continue to take cannabis, and the side effects for the long run might be very difficult. And we saw that patients who are smoking, many patients with head and neck cancer, has the highest risk for abuse, for addicted for the long term. And in the public, it seems very safe medication because the risk for dying after overdose is zero. But for the long run, there is a lot of side effects.
So we really don't push smoking cannabis at all. Vaporizers are still not quite legal here, and so it's and there's no. Australia's so anti-smoking that it's pretty hard to get cannabis on board. So it is interesting to see if different populations use it differently, have different outcomes.
Just following what from.
So you just turned yourself onto mute, Simon. Yeah.
Following from your ear said, it's not a highlight of a doctor's career to have caused young people to become addicted to smoking cannabis.
No.
And sadly, this happens more than we would want. But having said that, in Israeli society, I think it's fair to say that, smoking a bit of cannabis once a day, like having a beer at the end of the day, is considered socially very acceptable from a medical addiction or medical risk point of view. A lot of people would say cannabis is less problematic than alcohol. But then there is this subgroup that, they just can't manage without it. But they seem to function at a fairly high level. And if you have a glass of wine a night, so the argument goes, that's not that much different having some cannabis, but quite a few of them do become very highly dependent, not necessarily addicted, but very highly dependent on the cannabis.
It improves contentment with quality of life.
Yeah.
It does. And look, and I work with, we run a very large sarcoma unit, so we've got a lot of young people. And so I'm prescribing quite a bit of cannabis for chemo-induced nausea and vomiting in young people receiving sarcoma treatment. And so they're an interesting group that you really want to make sure that they're not on cannabis for a long period of time, and that it's something that they don't love. And so an oil, I find, that has a slow, gradual onset and it doesn't really give you that quick buzz that you get from smoking, is easier for people to stop at the end of a treatment. So it's sort of trying to get all the, learning, but it is a different society. I just remember getting off a bus in Israel for a lunch break, and all these kids are smoking cigarettes. And I'm thinking, why are kids smoking cigarettes? Israel at this in the year 2000 and it was 2019. But it is it's a different way of, it's a different.
It's also different the way we give it, because we don't wait. No one allows us to wait until they passed all the medications and now it's intractable symptom, and then you give the cannabis. It's not. People come even before starting treatment and they ask for cannabis. It's like the patient's right to have a cannabis. I have a cancer diagnosis, I should get cannabis. That's the way it works. And frankly, I don't think people need it for nausea and vomiting. We have excellent medications, most of them. Even with the oil, many people complain that they just give them nausea and the taste is terrible. So they switch to smoking. In Israel, 80% of patients that get medical cannabis smoke it. That's data that came out recently. Wow. So it's very different. And now also there was a study from Israel that showed that maybe if you start the cannabis before the chemo, you won't get neuropathy, which of course it was just a retrospective study and it doesn't show anything. But imagine the patients that read it, they all demand the cannabis even before starting treatment.
It's interesting, isn't it? And it will be interesting to see the difference between populations as cannabis becomes more, as our prescribing becomes more mainstay, and if people, and now as smoked cannabis is becoming available, so now I can give people leaf or give floss in through my pharmacy, and I'm only interested in prescribing it if I've got a vaporizer. So it's all changing. But I remember doing ward rounds in with the hospice of the Galil Elyon, and they're just going in Kupat Kolim with a bag of joints to give to the patient. And so it'll be interesting to see the difference and to see if it changes the way people cope with the cancer treatment.
Thank you so much.
It's a pleasure. Nice to meet you all. And I'm not allowed to be on the screen for a minute longer than now, so I'm going to say
good night.
I'm in my bedroom. Lovely to meet you all, and Mazal Tov on your new government.
Thank you. See you in Israel.
Take care. I hope I can get there and they let us out of Australia soon. Take care. Lovely to meet you all. Bye-bye. Thanks, Nathan.
Bye. Bye.